go ahead. Matthew's talk is on. So he'll talk on, see, we'll go in a systematic pattern. We'll go with the preoperative evaluation, the type of phaco procedure, and the stabilizing part of the phaco procedure, and then IOL implantation. And we'll come to the discussion at the end. Okay, over to Dr. Mathew.
Thank you to Team KSOS and Minu for this opportunity. So, zonal weakness, zonulopathy of various extents is pretty common in our surgical setting, and preoperative being prepared is very important. No financial disclosures related to this presentation. So it can be during cataract surgery, or subsequently it can also affect the intraocular lens. So we should be careful about that. The important thing to realize that it can be localized or diffuse, and it can be congenital or acquired. In the presence of a congenital situation, it can be like a coloboma, and there is a static small bag with a focal loss where a small amount of correction only is required. Acquired because of trauma, again there is a static, it is not a progressive lesion, and the rest of the bag is usually normal if the trauma is blunt injury. If it's a diffused one because of injury, example during a vitrectomy, there can be associated posterior capsular deficits as well, but diffuse with pathology, and that is the most important and critical criteria. Gradual progression will be associated with diseases like pseudoexfoliation, accelerated progression, example in homocystinuria. The etiology is multifactorial, marfans, homocysteine, usually a lot of syndromic things, so we should be looking at the general health of the person, not only for taking care at the time of anesthesia required in these people, but also to help to localize what is the possible type of syndrome that has caused this disease. And in adult onset, it is progressive. Pseudoexfoliation is the commonest in our situation, but retinitis pigmentosa is also pretty common. The clinical examination, and this is very important to identify family history. Many people would have forgotten the small childhood traumas, and this is important to elicit. Sometimes you may see scar on the cornea, you may see some local foreign bodies. People who are in the stone breaking business usually have blunt injuries. Visual symptoms may not be very typical of usual cataract. Systemic evaluation, like I mentioned earlier, is very important. Cardiac evaluation is compulsory for marfans. Ophthalmic evaluation, look again for phacodonesis, because subtle phacodonesis may be the only indication preoperatively that this is a person in trouble. Get the pupil as well dilated as possible. Ask the person to look extreme left or right while looking on the slit lamp from the other angle to see if the edge of the lens equator is visible. If it is round or flat, that gives different indication as to what you will encounter intraoperatively. Look for anterior and posterior capsular damage, and the density of the nucleus. If it's a hard cataract with this kind of a compromise, it becomes much more difficult to manage. Posterior synechia and presence of vitreous prolapse may sometimes be the only indications that there is a possible problem. Good glaucoma evaluation is necessary, especially in the presence of blunt injury. Look for iridodialysis, look for angle recession, cyclodialysis, a retinal evaluation to look for retinal dialysis or a choroidal rupture. And in cornea, assess the specular, because there will be a lot of intraoperative manipulation which is going to be critical if the cornea is already compromised. Most importantly, don't finish with a slit lamp examination. When in doubt, make these people lie down, because you may see a lens which is sitting there with some amount of tremulousness, but it goes to mid vitreous suddenly when you make the patient lie down, that may be the place where you get the anterior chamber depth irregularity or asymmetry, which will indicate that you have a challenge there. So a round or scalloped edge like this indicates that there is zonules there, but it is weak or lax. Whereas if you find a flat surface like this, it means that this is attached on the two ends, but there is no zonule at all on the flat area. So the management is different, and the likelihood of vitreous prolapse is much higher in this one compared to that one. Intraoperative challenges or preoperative challenges, visual acuity is not correlating to refraction. That may be one indicator. There can be lens-induced glaucoma if the lens is in the anterior chamber, possibility of decompensation. Sometimes there in the mesopic conditions, the lens will come forward, and when the patient lies back, it goes back. So we need to be careful about that. The lens itself can be mature or high-pitch mature, and flattening the anterior capsule is not possible in these kind of compromised zonules. Lens-induced uveitis may be present, imminently dislocating into the posterior segment. Once we finish the block, after giving the digital massage, we found that the lens was on the macula, so it became a retina case. And all these cases, retinal detachment is very possible. Intraoperative considerations, cataract surgery increases the risk of subluxation, vitreous loss, posterior dislocation, even IOL decentration at a later stage. Choice of anesthesia, whether you would give a peribulbar block or whether you would give a subtenance, is important. Wound, how you will position it so that you are not making your main tunnel in the area of dialysis and vitreous prolapse. The rexus must be centered on the bag. Hydro, you have to do a good hydrodissection and get a good rotation of the lens. Nucleus disassembly techniques will be covered later. Fluidics may need to be low fluidics to prevent fluid from going posteriorly. Choice of IOL and lens stabilization. So based on surgical experience, you will look at whether it is static or progressive. Static CTR may work, but progressive, you have to do some form of fixation with a suture. If it is normal cataract, you can go for a slow motion phaco. Very brunescent, maybe a SSCS or ECC is what will happen. Depending on the extent of zonular weakness, you can decide how to fix with what. No CTR, CTR, CTR with fixation, or a SFIOL or a ACIOL. Various devices, we should have this inside the OT, capsular hooks or the ASIA anchor. Intraoperatively, capsular tension ring, prevent the collapse of the equator, maintain the contour of the equator, tamponade the vitreous from coming forward, but it does not prevent the anteroposterior movement of the lens itself from where it is hinged. And the Bonnie-Henderson modification, where you have this kind of a corrugated structure, makes I&A easier in these eyes. When to insert the CTR? After hydro, full advantage of CTR is there. Safer removal of nucleus, but insertion may be difficult. And if at that time the zonulopathy progresses and you lose the lens bag complex into the vitreous, then it is much more of a challenge. After nucleus emulsification, better visualization, easier to insert, but then you may end up with a cortex entrapped in that. After IA, it's maybe for long-term IOL centration, but you have to be certain that you haven't lost the back by then. Various sizes are available. Larger size is preferable. The fixation, Sioni ring, and the Malugin modification, difference is that one, you suture at the middle, whereas the Malugin modification is suturing at the end. The capsular tension segments are much less bulky, easier to implant, and this is what I prefer currently. When it comes to counseling and consent requirements, we have to say what is the procedure, why it is needed, who will be doing it, make sure that it is always a senior surgeon that does it. Any other alternatives in these individuals, the side effects of the procedure, complications, and that is very high in this kind of a situation. Need for repeat surgery, especially make a note to say that you may end up aphakic at the end of the first surgery and may need IOL implantation as a secondary. Need for periodic review and possibility of complications. Thank you very much.
Thank you. Thank you very much, Dr. Mathew. This is a very crucial stage in subluxation. Once you identify subluxation, that you need to tell the patient and inform the patient. So what I do is I just show this patient the picture of the eye. I have a live TV connection. So the normal eye will be shown on a monitor, and this will be shown to them as their lens, which is not in the normal position. So first of all, they have to be convinced with that. After taking up, if something happens or if you identify on the table, it's very, very difficult to convince patients, especially in private practice. That is the most important take home for subluxated cataracts in private practice.